नमस्कार. परत एकदा आम्ही मेळटात लायव्ह ऑन विथ मणिपाल हॉस्पिटल्स या कार्यावळीन. अशी एक हिंदू मायथॉलॉजीन गजाल सांगतात की मनीसजात जेन्ना जाली तेन्ना सगळे मनीस घाण आशिल्ले, सारके जेविनाशिल्ले. म्हणटकीच शंकरान आपल्या नंदीक सांगलें की आरे तूं सकयल वच आनी तांकां सांग की दिसाक 3 वेळा न्हांव जाय आनी 1 वेळ जेवात म्हणून. म्हणजे सारकें जातलें म्हणून सगळें वेवस्थीत जातलें, नितळ जातलें. तो नंदी कैलासांतल्यान भायर सरलो आनी म्हणत आयलो 3 वेळा न्हांवप आनी 1 वेळा जेवप म्हणून. वाटेर मातसो तो बसलो थकलो म्हणून. फुडें येतना चुकलें ताचें सगळें आनी ताणें सकयल येवन सांगलें कितें की तुमकां शंकरान सांगलां 1 वेळ न्हांवप आनी 3 वेळा जेवप म्हणून. सो तेन्नाच्यान आमी 3 वेळा जेवतात, ब्रेकफास्ट, लंच आनी डिनर, आनी 1 वेळा न्हातात. हे 3 वेळा पळय आमी जेवतात, आमी पळय खातात. आतां फास्ट फूड पळय आमी खातात, हांचो परिणाम आमच्या शरिराचेर जाता. इट एफेक्ट्स अवर बॉडी. कारण आमी हांगच्यान खातात आनी द टेस्ट इज ओन्ली हियर ऑन द टंग. बाकीचें मागीर तें भितर वता पळय आनी दुसरे दिसा भायर पडटा, ती एक व्हडली पॅसेज हांगच्यान सुरू जावन थंय पर्यंत पावता. The whole system is known as gastric system. Gastroenterology. Enterology म्हणजे इंटेस्टायन्स, आत. त्याची स्पेशालिटी ही आता एक वेगळी ब्रांच जाल्या मेडिसिनची. आनी ताजे स्पेशलिस्ट डॉक्टर निखिल सूरज हे मणिपाल हॉस्पिटलान काम करतात गेले 6 म्हयने. ते आज आमकां ह्या सिस्टमेची आनी कितें दुयेंसां जावंक शकतात ताजी माहिती दिवपाक आमचे कडेन आयल्या. डॉक्टर निखिल, वेलकम. वेलकम टू यू. वेलकम टू यू.
Thank you.
Now, just in not short, but just explain to us what does this gastroenterology mean and what are the parts that are involved in this system?
Gastroenterology is the study of gastrointestinal system. Okay, so it starts from the oral cavity, then we have the whole esophagus, stomach, then you have the small intestine, and then comes the large intestine. After that, the end of the large intestine, you have the anus. So attached to this, there are some side branches such as the pancreatic system, pancreas and its duct, and the liver, gallbladder, and the biliary system. So this entire system, starting from the mouth up to the anus, including the liver and the pancreas, biliary system and pancreas, constitutes what is known as the gastrointestinal system. Right.
Yeah.
So the gastroenterology is the study of this gastrointestinal system.
Total, from the oral cavity up
From
to
the oral cavity
anus.
up to the
Now,
anus.
when we eat something, it passes through this long canal. Okay?
Yes.
Approximately what is the length?
Esophagus is about 40 centimeters in length, stomach around 20, then you have the small intestine which is in meters, again
Meters, huh?
meters, yeah.
Ah, so it travels that length.
Travels length.
And at every step there are changes which take place.
Yeah, every step, you know.
Every step.
Yeah,
Can you just tell us in short now what happens in oral cavity, what happens in the esophagus?
So oral cavity, you know, first we are breaking our teeth, our tongue, so saliva is there. So everything helps us in breaking down the food. And saliva, there are some salivary amylase. So these amylases, you know, these enzymes try to break down the food and help to digest. Okay, so that, you know, small portions and each individual component, you know, like we have to break it down to proteins, amino acids, fats, and so this, from all this, everything which we eat has broken down into individual carbohydrates. All these are broken down, then only it can be absorbed. So this process starts from the mouth itself.
Oh.
Okay, so first, you know, your what you call the teeth helps us in grinding these things, so you should chew a lot so that it is broken down into small pieces. Then mixes with the saliva, the salivary enzymes also act. Then it passes through the esophagus. This is tract, you know, to the pharynx, then to the esophagus. From the esophagus, not much of digestion happens, but then it enters the stomach. In stomach, you know, you have acid, so hydrochloric acid is produced again. This also helps. This is useful for the digestion. Okay, and here also food is mixed thoroughly with this acid, stays for some time there, and it slowly empties through the pylorus. That's the one end of the other end of the stomach, where the small intestine starts. There is a small orifice known as pylorus. So then the food goes through the pylorus into the small intestine. Here also in the small intestine you have the secretions, the fluids from the pancreas. That's the pancreatic juice which is coming in. Then you have the bile which is produced in the liver, then stored, concentrated in the gallbladder. Then it goes through the biliary, that's the bile ducts, and it enters the second part of the duodenum. So there these juices, this mix, fat is emulsified, proteins are broken down, pancreatic juice contains a lot of enzymes. So and then in the small intestine again that digestion goes on in an accelerated manner, and in the small intestine is also the main part where the assimilation, the body absorbs these digested materials. Okay, the fat bile helps in emulsifying the fat, and along the inner lining, the whole gastrointestinal tract, you know, the inner lining is known as the mucosa. So there are small lymphatic vessels in the mucosa. So they absorb this material, and this gets absorbed into the lymphatic system. Then this goes into lymphatic system, and ultimately thoracic duct enters into the blood. So and then the portal vein is also there, portal vein branch is also there. So like this the absorption starts, and slowly when all the important materials are absorbed, this gets converted into the rest of the excreted as the feces, and this goes to the large intestine, and from there slowly excreted.
So what is the time that once you chew the food, then for it to become dry and go into the large intestine?
Actually the whole this colonic transit takes place around 20 hours, 18 to 20 hours.
20 hours.
Yeah, and depends on the type of food which you consume and different parts, you know.
Exactly. Now I was coming to that.
Yes.
What is the type of food that is best suited for any gastroenterological tract?
The food with actually based on diseases, sometimes you may have to make adjustments, but the food which contains lot of vegetables and fibers, you know, fiber rich food, it's good, you know, that is for digestion, and you know, so that you know it passes slowly, and the patient also does not have this constipation and all those problems. So yeah.
Green leafy vegetables.
Green leafy vegetables, the vegetables which like beans, the plantain.
Those were.
Yeah.
And most of the time it is said that half cooked food is better than fully cooked food, something like that.
You know, sometimes overcooking, you know, leads to loss of the nutrients. So that's a you know, the salads and all much considered to be better. Yeah.
Now, if you consider, I mean, suppose we divide this into three parts: above the stomach, and then below the stomach. What are the common problems that you face here above the stomach, say oral cavity and esophagus?
Okay, oral cavity I will not dwell much, because anyway the dentist and everybody will take care of that much. Okay, and then you know, you have problems with motility. You have difficulty in swallowing. Okay, so the common problems with the esophagus, pharynx and all, you know, the patient may have difficulty in swallowing. This may be due to the imbalance, the rhythm disturbance between the swallowing process. Then patient may develop ulcers in his esophagus. Okay, then he may develop infections, candidiasis infections. Then the tumors like cancers of the esophagus can develop. Then another common problem which we encounter is sometimes, you know, patient may swallow something, foreign bodies. Then this another common problem with esophagus is in Goa and all, you know, lot of cirrhotics are there. So cirrhotic, liver disease patients. So they may develop dilated veins which are known as varices. So these varices, you know, they tend to grow, and they may, when the pressure raises in them, they tend to burst and bleed. So they may it produces vomiting of blood, that is known as hematemesis in medical terms. So these are some of the common issues, you know, which we deal with above the stomach.
Now you spoke about ulcers in the esophagus.
Ulcers in the esophagus.
Does it have anything to do with the type of food that you consume? Like more spicy food will give you more ulcers, something like that?
Ulcers in the food, much more than the food, it's basically due to infections like herpes and all. And this is not very, ulcers in the esophagus are not very common. Not common. But sometimes, you know, the esophageal mucosa undergoes damage because the acid which is coming back from the stomach, that's known as gastroesophageal reflux disease. So this acid which is because of the laxity of a valve which prevents the reflux of the acid at the lower end of the esophagus, so the acid comes back into the comes into the esophagus where it is normally not supposed to come, and so this causes damage to the esophagus in the form of some erosions. The normal lining is damaged, and this can even produce a change known as Barrett's esophagus, where what we see is the metaplasia, the normal lining of the esophagus is changes into another type, and on a long period, this may even produce cancer.
Sometimes you get that regurgitation, and a sour taste here.
Sour taste, yeah.
That is because of that reflux.
Reflux, yeah, acidic sour taste, and sometimes your mouth suddenly fills up with some fluid.
Correct.
Yeah, that's water brush.
Correct. And then ulcers are very common in stomach.
Ulcers are very common in stomach.
Can you tell very common reasons for that?
Ulcers. One is the stomach acid is always produced in the stomach. Okay, so this is for digestion, but what happens, the stomach gastric in the stomach, the inner lining, there is protective mechanisms so that this ulcer does not cause damage. But in case more acid is produced, or if there is any damage to the protective mechanisms like this, these are the common ways by which the ulcers can occur, and also in the background of some other diseases which may produce either of these. So like that, so here the type of the food which we eat also has a implication. Too much of oily food, too much of sour food like your imili, this can produce, and go and all, we have seen that a lot of patients are suffering from a bacterial infection known as Helicobacter pylori. This can produce more acid production, produce a lot of things, more acidity, this again produce damage. And then we have got people taking drugs like steroids, painkillers, analgesics. So all these produce damage to the protective mechanism, the defensive system. This can produce ulcers. Like this, lot of, and some diseases, chronic kidney disease, lot of diseases. You're taking aspirin for heart disease, like that. So there are a lot of causes, lot of drugs also which produce damage.
अल्सर जावपाचें एक खूब कॉमन आशिल्लें, आमी शिकताले तेन्ना, आतां कमी जालां तें. तेन्ना आमकां सांगताले की अल्सर कित्याक जाता, हरी वरी एंड करी, तीन हे. हरी म्हणजे फास्ट, बेगीन जेवप, पचूंक दिवप ना, कितेंय खावप. दुसरें म्हणजे वरी, चिंतप, टेन्शन्स, ताका लागून एसीड प्रोडक्शन वाडटा. आनी करी म्हणजे तिखट खावप. सो हरी वरी करी ही तीन जाल्यार कमी करत जाल्यार अल्सर कमी जाता म्हणून. आतां तातूंत चवथें काय आयलां तें ड्रग्स. आमी वेगळी वखदां घेतात. दोतोरान सांगनासतना खंय वाचतात, कितें पळयतात, कोणें सांगलें म्हणून वखदां घेतात. ती कसलीं आसता ती आमकां कळना, ती कितें करता ती कळना. तातूंत पोटाक त्रास जाता, आनी पोटाक त्रास जावपाक लागलो की एसीड चड जाता, आनी एसीड चड जालें की मागीर तें अल्सर सुरू जाता. How do one know that there is an ulcer? I mean, what the person will feel if I have an ulcer? What do I feel?
Patient, sometimes ulcers, can produce pain. They may be asymptomatic. Patient may be asymptomatic, okay, but usually they have pain in the stomach. Now this pain may be related to the food. He may feel that the pain is becoming more prominent after taking food. In some type of ulcers, but in some type of ulcers, he feels that the pain, is getting relieved after taking food. So this pain, which has got a relation to food, constant boring type of pain. So this is one of the common centers. Then if the ulcer bleeds, then it's again problem. So the patient will develop with vomiting of blood. It's not hematemesis. Then ulcer, then the patient can develop complications. The ulcer, olden times, now with advent of a lot of medicines, the ulcers, those problems are decreased in number, but this ulcer, if it is present at a strategic location, it can produce narrowing of the pylorus, that is the channel through which the food is passing. So the patient develops a stricture, and this, leads to stages of food in the stomach. Stages of food, and this reduces to stages of food, vomiting, and patient recurrent vomiting, like that. So these are some of the common. And then stomach ulcer. Stomach ulcer can also be a manifestation of a stomach malignancy, that's cancer of stomach. So it can also be present as a ulcer. So patient in this condition, patient will develop loss of appetite, he will feel he's not hungry, then he will have a loss of weight, like that, and slowly he will lose blood, vomiting of blood. These are some of the common symptoms.
Yeah. But there are also, doctor, patients who complain of blood when they pass the stools. So
Yes.
they notice blood in the when they go to the toilet.
Yes.
So there, what are the? I mean, this stomach ulcer blood goes through the stools.
Stomach ulcer blood goes through the goes through the stools. But what happens is, if the blood bleeding is small, if the bleeding is small, this will get altered. So the normal blood will get changed in color because a lot of the proteins are getting denatured, which are present in the blood, and they get digested, and this will become black in color.
Oh.
So that is known as melena. So the patient will feel that he is passing black colored stools. Black color of his stools. That's one of the manifestations of this stomach ulcer bleeding, which is passing. But if there is a torrential or large amount of blood which is being lost, this can manifest as, because there is no adequate time for the blood to get digested. So the patient may pass fresh that blood itself. Now, apart from this blood in stools, are thought lot of causes lower down the GIT, that we have divided it into upper GI bleeding, lower GI bleeding based on the duodenum, small intestine.
Yeah.
And then you can have bleeding from the hemorrhoids, very common. Then the patient can develop,
that is piles.
That's piles,
Yeah.
commonly known as piles. Patient can have ulcers from which may bleed anywhere in the common condition, like solitary rectal ulcers, he can bleed. Then there will be sometimes there's fissures and all, little bleeding, pain more. Then patient may have again tumors of their anywhere in the colon, very common. Then sometimes kids and all, they may have something known as fleshy masses in the intestine projecting inwards into the lumen. This is known as polyps. So this can also bleed. So there are a lot of causes. Again, small ulcers can develop anywhere. This can also bleed. Another common condition is known as inflammatory bowel disease. That includes our ulcerative colitis, Crohn's disease, not specific disease. So these are also common conditions.
Now, see, a patient comes with pain in the stomach.
Okay.
Correct. Now, how it is caused? I mean, it can be caused because of so many reasons.
It can be caused because so many reasons.
Just it pains here, the patient says. So, what are most common causes?
Okay. So we can divide it into something known as organic causes. Okay. So there is some organ which is involved. Sometimes there will be only rhythm disturbances. One common cause of pain abdomen, diffuse pain. Okay. We will not find anything organic. That is known as irritable bowel syndrome. Okay. Keep it aside from some time. So the patient may have pain from his, all the organs, they can pain from different organs. So if the stomach, he will have pain in some part. Okay, like in the usually in the left upper part, stomach related pain. Then an important cause of pain is what you call the pancreas. That's usually in the center, just below the upper part, just below the xiphoid process. Okay, so that's a terrible type of pain, and it can produce a lot of complications. So like fluid in the abdomen, effusions, renal failure, systemic complications. Okay, then another part is the gallbladder. So the patient may have gallstones, or sometimes even without stones, the swelling of the gallbladder, the inflammation which produces pain. So then the stone, if it is present, sometimes it may pass into the biliary system, and this produces biliary colic type of pain. Sometimes the patient may have
that is on the right side.
That's on the right side. That's on the right side. Then the patient may have pain from the liver. Sometimes because of the inflammation of the liver. Then patient may have pain from the intestines because something like obstruction of anywhere, then the intestine will be trying to contract to get over the obstruction, and this produces pain. Sometimes the pain may be due to ischemia. The blood supply of the different organs, it may be compromised. They may be decreased in it. So this ischemia, it may produce pain. Then another cause, very common in the lower right part, that's appendicitis. That's a surgical cause.
Yeah.
Okay. Another cause of pain, is ulcer. One complication of ulcer which I did not discuss previously, it was a surgical related. So the ulcers may erode, may slowly make a hole into the organ like stomach or duodenum, that's the intestine, and this may perforate into the that's the cavity, peritoneal cavity. This is a serious complication, and patient presents with severe pain and swelling, distension of the abdomen. There may be fluid. This is a surgical emergency.
Suppose there is something in the stomach ulcer, or there is something in the lower colon.
Okay.
Now what is the technology by which you see it? See, during our time there was something called as barium mill.
Okay.
We had to swallow barium and take x-rays and then track it. So that is gone.
Yes, sir.
Now what is the latest technology by which you can diagnose or find out?
We have got now, as you mentioned, sir, there we have a lot of methods now available. So important things we gastroenterologists in our arsenal include, the scopies. We have scopies. We have got the scope. We have the endoscope, which is actually a light source is there. Then through the optic fibers, the light will be projected inside, and we will illuminate the organ and capture the images which what we see on a camera. We project onto a monitor so that we can see it. We have got the controls.
How do you pass that in the stomach? Huh?
Yeah. So we this scope, for your to examine up to your upper the initial parts of the small intestine, we pass the scope through the we use the endoscope, OGD scope. Okay, and this scope, we pass through the stomach. We ask the patient to swallow. The scope, it's a long tube, a slender tube, and we have the controls will be with the gastroenterologist, the endoscopist, and through this the images will be can be monitored on the screen, and then we will be able to see what is the exact pathology, what's happening inside, and if needed, like if there's an ulcer and all, we can take a biopsy. If depending on the pathology, we can take the biopsy, and if there is anything to be done, then there is an for diagnosis as well as therapeutics. That means for treatment. Some of these what you call the pathologies can be treated. For example, if the patient is having varices, which can produce bleeding, veins. So they have modalities by which using an endoscope we can band it, we can inject some medicine into it. That's sclerotherapy. So there are different methods.
Is it painful? This procedure is painful to the patient?
No, these are like simple procedures, OPD daycare procedures, and we just give usually by local anesthesia. Local anesthesia is always urgent. Yeah.
So patient is awake.
Patient is awake, very much conscious, cooperating.
Nothing to be worried about.
Nothing to be worried about.
And patient walks in and walks out.
Patient walks in and walks out. Depending on
correct, but in normal case.
In normal scenarios, patient walks in and walks out.
And if it is for lower intestines?
For lower intestines, we have something known as colonoscopy. Colonoscopy, the scope is passed through the anus, and we usually give, there may be some discomfort for the patient, so we give anesthesia.
That is all.
That's all. And using this, we will be able to examine the whole of the large intestine of the patient and see if there is any polyp, as I mentioned, ulcers, tumors, all these things.
Now, I want to ask a very important question.
Yes, sir.
See, as age advances, we are told to do regular blood checkup.
Yes,
correct. Then after say 50s, we are told to do take your regular ECG, monitor your heart. Now similarly, do you advise regular scopy to be done? Like say everyone should get say from top esophagoscopy or gastroscopy done and colonoscopy done say once a year. I mean, is it so? Is it better?
Well, let me explain. Okay, so for colonoscopy, actually there are guidelines that after the age of 50, because some of these tumors may be indolent. You may not know there is something. So if there is no family history of any cancer and all, depends scenarios, different indications will be there. If there is no, if a normal person with no family history and all, we advocate a colonoscopy after 50 years.
Every year?
No, that if it is normal, then after 5 years like that, then monitoring.
But at least you must start at 50.
After 50, it is advised. And regarding endoscopy, based on the symptoms, anytime the patient, previously normal patient, develops new symptoms. He develops loss of weight. He develops difficulty in swallowing. He develops loss of appetite. Okay. Then there are some red signs. The patient develops anemia, and so these are some of the recurrent vomiting, change in voice. So there are a lot of things which will stimulate you to do an endoscopy.
Oh, I see, I
like
see,
that.
I see. आम्ही सदांच हार्टाचेर लक्ष दिता. वी आर मोर कॉन्शियस अबाउट अवर हार्ट. त्यामुळे ECG काड, एंजिओग्राफी कर आणि दुसरें ब्लड, बिकॉज ब्लड कॅन बी इजिली टेस्टेड. ताका प्रिस्क्रिप्शन लागना. म्हज्यान वचूं येता आनी सांगूं येता इमोग्लोबीन कर, फास्टींग ब्लड शुगर कर, आमकां पाठ जालां तें सगळें. पूण आमी जगपा खातीर दीस रात खातात पळय, तें ज्या ट्रॅकांतल्यान वता ताज्या खातीर मात आमी कांय करना. मागीर केन्नाय रगत पडलें म्हाका संडासान अशें म्हणटकीच मागीर धांवपळ सुरू करता. ना ताका त्रास जाता, गिळूंक येना अशें म्हणटकीच धांवपळ सुरू करता. पूण जशें हार्टाचेर लक्ष दिता, जशें आमी ब्लड टेस्ट करता, तशें हो GI ट्रॅक्टूय टेस्ट करचो पडटा. आनी म्हणून डॉक्टरान सांगलें की 50 वर्सां जशीं जालीं की पयलीं कोलोनोस्कोपी करून घेवंक जाय. म्हणजे व्हडलें इंटस्टायन, लार्ज इंटस्टायन पळय आसा तें चॅकअप करून घेवंक जाय. आनी मागीर दोतोर सांगता तें आयकपाचें, कित्याक लार्ज इंटस्टायनाचीं दुयेंसां चड जातात आनी तातूंत पॉलिप्स म्हणून एक दुयेंस आसता आनी कॅन्सर जाता. हें पयलीं जाल्यार कळ्ळें जाल्यार ताजेर उपाय करप बरें. त्यामुळे जितलें लक्ष आमी बाकी कडेन दिता तितलेंच लक्ष तोंडा पासून सुरू जावन सकयल पर्यंत वता ह्या ट्रॅकाचेर आमी तितलेंच लक्ष दिवंक जाय. जिबेचेर ताबो दवरूंक जाय. आनी हें सगळें जालें आसत जाल्यार कमीत कमी दुयेंस आमकां जावंक शकता. आमकां ही सगळी माहिती, इतल्या व्हडल्या ट्रॅकाची माहिती थोडक्यांत दिली. ताजे बद्दल सगळ्यांच्या वतीन दोतोराचे आमी आभार मानया. डॉक्टर निखिल, थँक्स फॉर on such a long track. You have precisely given a very concise information. Thank you very much for spending your valuable time and coming here. Thank you.
Thank you, sir.